to the cloud.
Yeah. Okay, thank you.
Okay.
Yeah. Sorry. We can now.
Okay.
Yeah. I think you have to share or what? The rest to share again.
All good?
Yeah, all good. I think you have to share again your screen present.
Oh, okay. I'm going to have to share that again. Can you see my screen?
Yes, thank you. Yeah.
Okay. Okay. So as I told you, basically, in the back one, I'm going to go with the immediate implants always help you to avoid any second multiple surgeries. And especially in this COVID time, of course, everybody likes to do the surgery in one time. So immediate implants will save you all those multiple appointments coming back after and the healing time. And anything in the dentistry, anytime it comes, it has a cost. Either it can be physical cost in the terms of dollar or the rupees, or it can be chair time for any dentist or a provisional. So the cost is the biggest impact. Now, I would say, briefly, when you're going to use the immediate implant, anytime if the tooth in the front area, which came in is broken and it's non-restorable, or if the restorative with the prosthetic crown may be non-favorable for a very long time, or any situation when you have endotreated teeth, which is failing and retreatment is not possible. Many situations, the tooth can be restored with the crown, but external or internal resorption is very much a big problem. At the time, teeth warrants for extraction, and either from the skull or it may be through any kind of car accident. And people usually break their front tooth because that's more prone to accident. Now, there are certain criteria you do immediate implant, but I would like anybody to avoid implant or maybe consider cautiously. If there is infection present, you want to make sure that you try to stay away from immediate implant because your healing will be compromised. At the same time, if you have a buccal defect or your bone, you don't have a proper bone structure and it's a compromised socket, you would want to avoid immediate implant. If patient has a very severe perio condition or inflammation, that will also affect your healing. And we want to make sure we control the infection phase first before we attempt to the immediate implant. Now, the mainly indication are more of fractured teeth, or if somebody has a root canal teeth and the ferrule is less. Like specifically, I'm going to share this example, which the lady who's 59-year-old, she came to the office on the 31st December. She was planning to visit out of the country with the husband, but now breaking the front tooth was a problem for her. Definitely, we can take the tooth out, we could make the flipper, but while knowing properly, we were able to present her an option where we can take the tooth out, place the immediate implant, and give her something to smile while she's on the vacation. Way you can restore prosthetically without doing extensive surgery, or even after doing that surgery, there is a chance of not having a long-term prognosis. You can see here the smile line. Of course, patient is very aesthetically driven, and when she's traveling out of country, she wanted to make sure she has a better smile going in there. We were able to carefully take her teeth out, place the immediate implant, and I want to make sure anytime when you try to place the immediate implant, there are certain things which you really want to make sure. You want to make sure that you have enough bone, 3 to 4 millimeter in the apical area, because once you take the teeth out, you want to engage that apical area so that you can capture the primary stability. Also, you need to make sure there is a 2 to 3 millimeter side interdental bone available from the next tooth, because you don't want to impinge on the enamel on the cementum area on the next confilateral tooth. Now, if you look at this graphical picture here, 2 millimeter on the either side is minimum needed. There are certain situations you can get away with the more bone, or sometimes if it's the less bone, you may have to select your implant size accordingly. Biggest criteria for immediate implants are, I usually go with, it should be 3 to 4 millimeter subgingivally from the CEG of the adjacent tooth, because you want to make sure you have a proper depth to create that emergence profile so that you have enough connection for your body. Also, when you do immediate implants, you always see the resorption. You want to make sure the resorption, you are compensating for the resorption. Other biggest things that you may have to make sure anytime once you place the implant, before you pick the bone graft, make sure you place the cover screw, because you don't want your bone graft particles to go in that, because it will be very hard to retrieve them. So place your implant, place the cover screw, place the bone graft, and then followed by the provisionalization. After placing that implant, we were able to give her a provisional crown, and at least she was able to go back to her vacation. That's the biggest thing, and that's a smile you can give it from your patient, and that's a service you need to start providing if you are comfortable giving the immediate implant. Now, other situation where you can use the immediate implant concept is if your tooth are not root canal, it can be if you see the gross decay. Like this example, patient is 59-year-old, same. He walked in the clinic with aesthetic concern. He said, "Doctor, I have a big hole in my tooth and I'm not able to smile." Of course, pain was not a bigger issue for him as aesthetic was issue. Now you need to start looking at those aspects when patients are telling and their patients are more aesthetic driven. If you give them an option of taking out the tooth, healing for 6 months or 8 months, they will not be happy, and it will be limiting from them to move forward with the surgery. Now, in this situation, we convince him we were going to take the teeth out. We're going to place the immediate implant, and we're going to make sure we're going to give you something to smile for temporary until you come out. Now, in this case, I tried to doing called PET technique, which is partial extraction therapy, where on the central incisor, which is broken, carefully we went there and with a surgical burr, we took the crown portion out. After that, we were able to preserve that buccal aspect of the tooth. It's a very complicated surgery, but once you start placing enough bone, you can easily get a hands out of it. It's a complete like a different topic for discussion. But if you are attempting the partial extraction therapy, you need to make sure that shield, which is left over, is very stable and at least 3 to 4 millimeters from subgingival area. You need to place your osteotomy on the palatal side, the new osteotomy. And the way I told you, you try to engage the apical portion so that you have at least primary stability. You place the implant, place the cover screw, and place the bone graft. As I told you, I have learned many ways where I've tried to place the bone graft and I forgot about placing the cover screw. It took me a long time to retrieve those bone grafts. So you really need to make sure you really remember to place your cover screw. We were able to place the implant. As you can see the implant here, I always place, whenever I plan immediate, I try to go with the subcrestal approach because you need to compensate for any kind of resorption you're going to get on that. We created the temporary crown from the polycarbonate crown. And I'm going to walk you through all the steps, how you can create the provisional techniques in the later. We give the patient a temporary crown. You were able to walk out with a smile to the patient. Now, why I started placing the immediate implants? Of course, I would not recommend anybody to start with the placing immediate implants in the anterior region if you are beginning your implant journey. First, you need to start placing the posterior implants. Once you start feeling comfortable, you can move it to the implant. But the reason for me to moving the implant in the immediate implants are basically in this kind of situation where you can see when you take the teeth out and you try to place the implant, you lose all this soft tissue architecture. The intradental papilla, which is very, very important part of aesthetic, you're going to lose them. There is no way you can bring those. If you look at just the X-ray, we as an implant dentist, we really worry about looking how your implant is. Is it the center? Is it subgingival? But we completely forget the soft tissue aspect of that one. The way you look at that, I have done many cases like this, and I have learned the way, and I started to feel. And some of the time, you get the patient from the oral surgeon who placed the implant, and now you have to restore it. It's become very challenging if you don't know. As I told you, I have learned it. I have made many mistakes, and all my mistakes have brought me here because I try to improve. I usually want people to say, once you start, you're going to choose the easiest case. Learn the difficulty which you're going to face it and try to improve from that one. I want everybody who's placing the implant or who is going to even thinking to get in the implant field to start placing implant goals should be differently. I know everybody, we think like my goal is to place an implant, but instead of thinking, if you change your perception that instead of placing the implant, if your goal become to how you can mimic the soft tissue architecture so that you can use your provisionals or a final crown and use the implant as a mean of that solution, you will completely look at their placing the implant as a very different way. And today, the same thing I'm going to focus on is a two-way. How can you create this soft tissue profile? And once you create it, what are the techniques you can use it to transfer that information to the lab? Because tissue will always be the issue. Tissue has, it's like a soft tissue. Any kind of trauma, they react well. They can shrink and you will lose that soft tissue profile immediately. You have to deal them very delicately. Developing emergence profile through interim restoration is a very important step because you need that biological stability. That biological stability will depend on your provisional technique. Now, once you have that provisional and you create that biological tissue, it's very critical you need to transfer that information to the lab, because when you create your abutment, when you get it from the lab, it's not just like take the impression, make me a screw retain crown or abutment. You really need to capture in very precise way. So whatever hard work you have done for 6 months, they can give you exactly the way. Otherwise, they can easily mess up all the soft tissue profile you have created because they don't know. Now remember that the emergence profile design will be very different. Anytime when you create that tissue or emergent profile, the buccal profile which you create is very different. And I'm going to tell you all the 3 principles where you can create and how you're going to choose that shape of that either abutment or the provisional crown. The quality and quantity of soft tissue around the implant are both aesthetic and biological important. Now, anybody, I told you, who really wants to be aesthetically driven or they want to place any immediate implants, I want them to go with these 2 articles. They are very, very important before you even place your first implant. The first one, which is Hansen, so they placed that, this article is 2010, but the other one with the Gomez, they came up with this new principle of biological concept of implants in aesthetic zone in 2021. And before I show you how you create it, I want to show the basic principle you need to understand before you create the soft tissue profile. So first, I'm going to talk to you about this graphical where it says that when Hansen Su in 2010, they came up with the 2 criteria. On the post-healing socket, free gingival margin is a critical contour area, they say. And from there till the tissue level, there was a subcritical contour. Now, when Gomez, they decided that the subcritical area has also very important role. And they usually talk on the 3 zone, which is E zone, which is very critical zone, made up of keratinized gingiva, B zone, which is the volume profile, and the C zone, which is the connection area. Now, if you look at all 3 separately, the first is the C zone, which usually start 1 to 2 millimeter right from the implant area. And it should be very critical because you don't want to make that C zone, that area very wide enough, because if you make it too wide and if you over contour, you can easily put a pressure on those gum area, not only gum area, but the crestal bone. And you're going to start having a resorption. So from a biological
నాకేం తెలుసు మీ నాన్ వెజ్ లో నాకేం తెలుసు
before I explain you to the C zone, I'm going to talk about the E zone is the emergence profile and is responsible for the final aesthetic contour. That's mainly the area which decide your free gingival margin. And that should be dependent on the contralateral tooth or the tooth which is you are replacing. You need to make sure you preserve the same architecture. B zone, which is connecting part between the E and C zone, which was never been considered important, but according to the Gomez is very important because that fills up the volume. And you need to, that's the biggest zone which you are having. You need to shape those crown areas so that you can properly create the soft tissue, you can create the keratinized gingiva and the bulk. Now, as I told you, very important part of the lecture is how you're going to create that emergence profile. There are 2 ways you can create it. After placing implant, you can make the provisional crown, which is temporary crown chair side, and create that profile. Or you can do the custom healing abutment. Somebody who is starting to place the immediate implant and they want to create the biological sulcus and everything, I would ask them to start with the custom healing first before they go with the provisional crown, because provisional crown takes little chair time and it is little complex procedure. But once you get a hang of it, it's very easy to create it. And once you start making it, once you come into the flow, you can easily make like multiple crown in a matter of 30 minutes. Now, second part will be focused of the lecture would be once you create it, how you're going to use the either intraoral scanning, if you all have either somebody has iTero or the 3Shape or any scanner, how you're going to capture the soft tissue profile, because that's also a challenging part. If you don't have intraoral scanner, I'm going to show you the technique of impression techniques, which is making a custom impression copy. So first, let's start with the provisional crown. The way I told you before I start, I want you to learn about how you look at your perception. This is, I used to live in New York. I used to look at the New York skyline as differently. As soon as I used to come into my clinic, I look all my implant part as a perspective, very differently. For me, that's my skyline. But once you start looking implant dentistry with the goal, where you're going to end up, I want you to start with the thinking your end in the mind and plan your surgery in a reverse way. That will be very easy for you for the aesthetic part. Now, let's start with the provisional crown first. This patient was 34-year-old patient. She was actually going through Smile Direct, where she was planning to get her clear aligners, but she broke her lateral and she came to the office was asking for the replacement of that tooth. Of course, she was very sad that she does not want to live with any single day without broken tooth. Now you can see that she has a very good amount of keratinized tissue and the bone surrounding that implant. The papilla was already present. It was challenging for her because of her bite. We were able to convince her that we're going to take your tooth out and we're going to place an immediate implant with the provisional crown, because she doesn't want any abutment, not even S6 retainer or anything. To get it implant, this is the time you have to spend a more. The extraction should be reserved every millimeter of bone, especially the buccal. You can use the help of either piezo if you have it in your clinic, you can use the periotomes, but it should be very atraumatic because you want to make sure you preserve side bone, which is mesiodistal bone, and the very important, which is the buccal bone. So I would advise anybody to take your time, do not rush for the extraction, because it's very easy to fracture buccal plate. As soon as you fracture the buccal plate, your immediate implant is out of the question. Because if you are very qualified, you can still do it, but it will require a flap, creating a membrane and everything. If you really want a clean and nice surgery, spend your time for the extraction. You will be happy that you spend 10 minutes extra in extraction rather than completely abandoning the case. Once you take the tooth out, we place the immediate implants, try to engage that primary bone 3 to 4 millimeter down. Because she has the clear aligners trays with her, we were able to place the clear aligners to check whether the implant is placed appropriately. And we try to bring the access screw on the more palatally. I'm going to talk to you more about bringing the access screw on the palatally. In this case, we were able to bring that on the palatal aspect, but since I've started doing it, nowadays, I don't try to aim with the mind that I'm going to try to get my access screw more palatally, because first, you need to place the implant in available bone. If by chance you are coming through the facial side or palatal side, there are many advantages available right now, either angulated screw channel or custom abutment. You can easily change that prosthetically. Do not worry about always trying to aim for the buccal access hole. Now, once you place it, always take a peak abutment, which is plastic peak abutment. Most of the implant company, when you use it, it's very easily available. Some of the implant company provide the metal one. I usually like the plastic one because you can easily bond them much better. Take your polycarboxylate crown, temporary crown, which have it, or sometimes many cases are use the patient on broken teeth, make a little window. Always try to bigger window because you want to make sure that it fits passively. Very narrow window there. Mark it with either a denture marker or any pen or pencil, but make sure you have enough window available there. Place the temporary crown back there. You can use acrylic or monomer. I usually use the flowable because it's work very easy. You can flow it and you can cure it easily. Put it in there. Fill the voids with the flowable composite. Unscrew it, take the peak abutment, and you're going to come out with that temporary crown. Place the implant analog and start marking the contact area. Now you have to be very careful in how you shape the crown, because once you start polishing it, the critical part will be how you shape their buccal facial profile. As I told you, that shape is very much important to creating the soft tissue profile. So you first, when you make it, always put the more composite, make it over profile. You can easily clean it, and before you make any adjustment on the facial profile, I want you to think about 3 aspects, which is your implant position will define the shape of the buccal area. If your implant location is, if your implant is placed more towards more buccally, the shape of that facial profile here, which you look around here, it's going to be either concave or it's going to be as straight as possible. You don't want to have a more concave or more bulky area because your implant is already on the labial side. Now, if your implant is more centered, you can easily make this concave, because at this time, you not only have to support the area, but you have to create the bulk to create the B zone. Now, on the contrary, there are many situations where you have to, most of the time, ideally, you have to place the implant on the palatal aspect. And you can fill this jump gap with a bone graft particulate material, 2 to 3 millimeter. Now, whenever you decide this, when your implant is more on the palatal side, you have to make sure your facial profile is convex. The advantage of that convex is you need to make sure when you fill this jump gap with the particulate bone, this will act as a barrier and a membrane. Also, your soft tissue can easily be supported by this convex profile. If it's under contour, you're going to have a recession. If it's over contour, you're going to have an implant showing off after 6 months. So these 3, either it's a center, buccal, or palatal, that will define your buccal profile outside. Once you start doing it, you will easily get an idea of how to shape those buccal profile, because that's a very important part. So same, back to that patient, we were able to make the temporary crown with the polycapsular crown placed in her mouth. We usually get at least 30 to 35 Newton stability. Now, if you notice in this case, I try to create the narrow neck, and that's, I would advise everybody. There are situations where before I used to start making those provisional crown, and I was not careful on polishing on the side area, I would end up blanching those tissue. I rather have a narrow crown and let this keratinized tissue grow more. I would rather end up with the more tissue rather than having a less, because if you have a more tissue, you can easily push them with your abutment in the later stage of prosthetic phase. So if you can look around here, at the same time, the surgery was very clean. You can easily place your temporary crown here. You can easily make sure the patient is happy with it. Make sure all your temporary crown is out of extrusion movement or lateral extrusion movement, any protrusive movement. It should be completely out of any kind of touching. You need to make sure that's a very important part of any immediate provisionalization. If you can put her on any night guard, or you can give her a retainer, that would be even more ideal. Now, this is the case was for making for the temporary crown with the provisionalization. Now, the way I told you, if you are starting with the provisional crown, it's a little challenging to make those crowns. You can start with the custom healing abutment, and these are very easy to make it. Once you get a hang of custom healing abutment, you can progress to the provisional crown. Now I'm going to show you the technique for the custom healing abutment. I'm going to use the example of this patient. Patient is like a 40-year-old. He was a smoker and he broke the tooth. I was not ready to begin because of a smoking history about the placing immediate, but because of his request and after signing a consent and everything, we were able to place the immediate implant. Look at his tooth. He broke the lateral exactly at the gum level. There is nothing left for the restorative part to create any crown. If you look at the dentist in his mouth, on the left side, when he has done all his dentistry, look at the soft tissue. This is exactly what happens if we really don't focus on the biological aspect of the soft tissue. This is this case I want to use in an example why anybody who's placing the implant or trying to restore it, you really need to respect the soft tissue, because without respecting the soft tissue, of course you can deliver the prosthetic result, but it's not going to be as ideal as possible. So what you do in this case, to create the custom healing abutment, always use this plastic peak abutment. You can take the peak abutment. I usually have this custom made shape. You can easily get it from your lab, and if you need it, I can send you the detail of how you can create those various shapes, so it's become easy for you. We'll put that peak abutment inside and use the flowable. I used to use the white flowable, but now I usually use that pink flowable because it's like a matching to the gum and it looks more aesthetically easy. Cure the light. When you take this one out, this is what you're going to end up with. You're going to have a peak abutment and a platform of flowable. Now you can see that there is a void here. You can easily take a flowable composite and fill those void. Now, as I told you, if you have a good assistant, you can ask them to make those couple of custom healing abutment already pre-head. If you really want to make it properly, I would say I use the hex abutment, but nowadays there are non-hex abutment also coming. You can use those non-hex abutment because if you don't have those hex, you can put them in and you can just torque them. You don't need to worry about the buccal lingual position. Now, when you make them, always make them over contour because this will give you an idea. It will give you enough bone, like a bulk volume. If you end up placing the implant more buccally, you can easily trim this area. Or if you place more palatally, you can add in this area. So this is the soft spot. You make this and you can change your abutment as needed. If you really need to clean them and you shape them, the best way is to use a football bar. Take a football bar very carefully, make it the shape so you can make it easily tissue profile. Like you can create the anatomy of the soft tissue coming out of it. You need to be very careful in polishing this because once you finish it, any abutment needs to be as clean and as much as polished. Now you can see that you can end up with this. If you follow the procedure, you can easily get from custom healing abutment very easily and make this as a stock healing abutment for yourself. Now, this is what you're going to end up with. But I want to make sure, if you really remember the Gomez article about, if you know where you want to end up, this is not arbitrary, I designed it. I designed for a specific reason. And that is the shape has each three compartment, which I was talking about, the E zone, B zone, and the C zone. If you really look at it this way, which we talk about the zoning first, from implant here, this is the C zone. You need to make sure it's narrow because you don't want to make too much pressure on your the bone area. If it's too much wide, it's going to create the pressure on that crestal bone, and you're going to start seeing the resorption. The B zone, which is 1 to 2 millimeter, you need to make it very much based on your ideal implant location. And the E zone, which is 1 to 2 millimeter, should be flat because you want your free gingival margin just to rest there. It should not be providing any kind of pressure because if it's a pressure and if it's the now for that, back to the same patient, you can easily see how much, look at his gum tissue. Where is stapled gum? There is no way, if we take the tooth out and let just filled by primary intention, we're going to lose all this papilla. So we decided to take the tooth out, place the implant. This is a palatal view. You can appreciate how much bone you have it on the palatal side. And idea was to preserve as much of gum tissue here. Took the tooth out, place the immediate implant. you can see here, we try to approach this 3 to 4 millimeter. The best way to ideally approach is try to look at the contralateral teeth and the apical area. If you think that you have enough bone, I usually advise you to go 3 to 4 millimeter or a 5 millimeter more deeper, because that's where you're going to get your primary stability. After placing the implant, you can see it's, I usually place the subgingival and the subcrestal, because I want to follow, after placing a bone graft, I want to create that profile for the C zone to the B zone. We place that custom healing abutment. As soon as you finish it, you place the custom healing abutment, take the bud, and take out that excess peak abutment. Now look at this. This is the same day of the implant. If you put this abutment, custom healing abutment, you can keep the implant surgery very, very clean. You don't have to put up stitches. You don't have to have a membrane. All your bone graft is very easily contained with this custom healing abutment. Now, the biggest thing which I told you about, as soon as you place it, you need to be very careful. There should not be any pressure coming on this pregingival margin. If you notice, take up the fine burr, go around and clean that area. Because I usually try to under contour, because I want the gum tissue to grow, and I will end up with the more tissue, because when I have a prosthetic abutment, I can push those tissue. It is very hard. If I have an over contoured abutment here, I can easily put a pressure, and that pregingival margin is going to start shrinking. You can see this is the same day of surgery. Now, patient came back after 4 months. Look at how much the healing. Your keratinized gingiva, it's stayed exactly where we started with it. You can even see the staining of that margin area. It remained exactly where we end up while we're taking out the tooth. If you compare with, this is where we started with it. This is after 4 months of implant. Just because of having that immediate custom healing abutment, you can easily preserve that papilla and the gum tissue. Imagine if you have never placed that custom healing abutment, it's going to be flat. You're going to lose all that papilla, and patient will not be happy. This is the side profile. Now, again, if you really notice that, look at the tooth, the width, and my custom healing. As I told you, I always try to keep a narrow, because once you're narrow, when you try to restore it, you can easily make it wider and make it the blanching of the tissue, rather than making over contoured abutment and having a less tissue. Look at this. This is where we started with the implant. This is the same day, and this is after healing, 4 to 6 months. Look at the buccal profile. You are able to preserve the buccal bone and keratinized gingiva. And then your surgery will become clean. Your implant will be stable. This is the technique where you're going to make your custom abutment. I'm going to talk more about this technique later on in the section where you're going to replace how you're going to capture that to the lab, because this was your custom healing abutment. Now, this is in the patient mouth. You have to give a lab certain kind of information where they can easily create that custom healing abutment and replicate that nature. So this is the situation, but I'm going to talk more about that. You take the impression. Now, when you create that custom shape of profile with the biological profile, your job doesn't finish at the time, because actually it even become more critical. And at this stage, if anybody who is just replacing or restoring the implants, if you are sending implant placement to if you are referring out your implant placement to the oral surgeon or anybody after healing, or maybe you start placing the custom healing abutment, or your oral surgeon is placing custom healing abutment, when they come to your office, you need to know how you're going to capture that information and send it to the lab so that they can exactly create the way you want it. There are two ways. Either the way I told you, you can use the intraoral scanning, which is nowadays very much available and widely available. First, I'm going to show you the case where I've used the intraoral scanning. This guy, he broke his lateral at the gum level. Again, this tooth was non-restorable for any means of prosthetic. We were able to scan. I have an iTero scanner in my office. I have used a 3Shift in the past also, but I prefer the iTero because we do a lot of Invisalign cases also, so that comes very handy. and we have a printer. You can if you don't have it, you can easily ask the lab to print the model for you. I always print the model to begin with because this is the diagnostic model you have it to begin with. If you need really, while it comes to the prosthetic phase, if you need any kind of information, you will have it. You can see from the same palatal aspect, tooth is completely broken. Now this tooth was more towards the palatal side, and we were working with the very less bone in the buccal side. If you are using the 3 shape, and if you are working with the intraoral scanner, you can easily create implant guide. If you are going with your first implant, make sure you go with the guided surgery. We were able to create the guide surgery for him because if you look around, the patient has very thin buccal bone. Anytime when you place the immediate implant, it should be planned on the palatal aspect because your maxilla always resolve backward and downward. Also, if at all, if you have any kind of jump gap, you can fill with the particulate bone material. So we were able to create with the plan on the same day when patient came back. We took the tooth out carefully because the buccal plate was very thin. You have to preserve the buccal plate as much as possible. Now, this was a challenging part also because the central incisor was the implant. So we wanted to be as atraumatic as possible. We placed the implant, we would be able to place it custom healing abutment. This is the X-ray of after 6 months. You can see how much bone you are actually able to generate. This is only because if you place the custom healing abutment. Without custom healing abutment, if you really see, all this interproximal bone will start to resorb at certain flat level. Same as it before, I was able to capture. I was able to make that custom healing abutment. You can see the shape would be different because this time the implant was more on the facial side. So I wanted to keep only flat profile. As soon as you take the implant, if you take the tooth out, place the implant, place the healing abutment, custom healing abutment. This is exactly the same day of a surgery. Look at the palatal aspect. There is a gap. We were able to fill the gap, and secondary intention will heal this. If you really place this custom, you can keep this surgery very clean. Also, same as I told you before, I keep this healing abutment very narrow because I want this gum tissue to overgrow. Because as I told you, you always want more tissue rather than the less tissue. After 6 months, this is where we end up. You can see that interproximal papilla was developed very profoundly. We started with it, look at the papilla, and this is where we have it now. As soon as you take your custom healing abutment, this is you're going to end up with it. And this is what exactly you wanted. Now to give it back to the lab, what you're going to do is you take your scanner and you're going to make sure you scan all the teeth with this area. It is very hard and challenging to capture if you place the implant very subgingival or subcrestal, but if you give enough time, you can easily capture all the information through the 3 shape. You take another scan after placing, in this case, we put the biomed encode abutment, place it, take another scan, which you're going to capture with this scanner. After that, you put your healing cap back and take one more scan. Now you have enough information to give it to the lab. If your lab is very careful and if they are skillful, they can easily mimic what you started with it and what you have ended with it. They need to merge all the data and they can easily make the implant crown for you. Now, many of the patients are fortunate that they can easily find a dentist where they can place the immediate implants. Now, in your clinic, if you are placing the implant or restoring the implant and you have a scanner, it is very easy because your chair time will be less. Now, for anybody who is doing it, and if you don't have a scanner, it's not the end of the world. You can easily modify your technique for the PVS impression and give them exactly the same information, sometimes even better information than the scanner, because scanner has a very limitation to capture the subgingival margins. And I'm going to show you one more case where you can easily do this old technique of PVS impression. So same way we talk about the intraoral scanning, now the PVS impression. Now this patient, she was missing with the lateral teeth. She never had an opportunity to place the immediate implant at the time, and she lost all the papilla. Also, the buccal bone had a defect. We were able to place the implant. We placed particulate bone to make a fill and give a little bulk of that. Now, if you notice here, instead of placing the incision more towards the center, I placed the incision more on the palatal area, because when I started the case, I did not have any intradental papilla and I wanted to create the papilla. What we did after creating the crown, I kept those, it's called like a pedicle flap, and kept it on the buccal side and left the palatal area healed by secondary intention. And this is the area you can see after 3 weeks. Papilla was formed on the mesial side. Distal style, I was on the aspect I was still seeing is like a very immature papilla, but we talked to the patient, oral hygiene placed on the chlorhexidine, ensure her how to keep the flossing, and we showed her the technique. And I was hoping that it's going to develop, because my aim was to develop mesial and distal papilla. Now, as I told you, this was the temporary crown we developed for her. The buccal aspect, the shape, is a flat, which is very different than the first case which we provide. And all depending on, because this case, she did not have that buccal plate. So my implant was mainly placed towards the buccal aspect. So I end up with having excess screw on the facial aspect. Same the slide which I told you, anytime when you have on the buccal aspect and your implant is placed more labially, try to keep it straight or a concave profile, because you don't want to create too much pressure on that gum tissue. Always make sure you check your implant crown 360 degree. Take an extra effort to polish them, because you do not want to have any kind of debris of composite material or polishing material, because it will affect or create the infection. You can see here there is a excess screw which was coming more towards the facial aspect, but I was not worried about it, because I usually worried when you have more techniques available on your skill level, you're going to start feeling comfortable, because you know that how you're going to restore it, how you're going to correct it. I usually say that if you only have a hammer in your hand or in your toolbox, everything's going to look like a nail to you. But if you know that you have so many other techniques available, and nowadays most of the people, as you know it, there are either you can make a custom abutment, which we did in this case, or angulated screw channel. Even if you are aiming for a screw retained crown, you can use the angulated screw abutment, and your screw will be prosthetically, you can change it to the palatal. This is the patient still in the temporary. After 4 to 6 months of healing, you can see how much of papilla we were able to grow it. I still had that buccal area, like on the temporary crown excess on the facial side. I was not worried about it. We told the patient this is temporary. Right now, all I'm trying to create is just the soft tissue. Look at the amount of stippling of the gum. Look at the papilla, very healthy. This is exactly you need to, and this is still in the temporary phase. We took that temporary crown out, and this is what we see. Very well healed, biologically driven, soft tissue profile. Any dentist who place it or any dentist who restore it at this stage, this is exactly we need to aim for it. You can even see the capillary formation of the bed here, because this is the B zone which I talk about. Now remember, as I told you, I did not end up here arbitrarily. This was completely planned. I knew exactly where I want to be there. And I created my way around through the use of temporary crown and making provisionalization. Now you remember the slide which I told you at the beginning, that E zone, B zone, and the C zone. Look at the C zone. This is just the connective tissue. Possible. There should not be any wider, because any wide will create any pressure on the gum tissue or the bone, and you're going to start having bone loss. This is the E zone, which is the critical part. It is made up of mostly keratinized tissue. Now the biggest, which is for me is a very critical aspect, is the B zone. Now this is a connective tissue. That's where all your capillary. Now, the way I told you here, at this stage, as a dentist, when we see this final result, we feel like, okay, this is like my $1 million result. But do you really think the patient care about this? Only for implant dentists or restorative dentists, this is the, we hear this important. Patients care about what it looks in the after, like a final impression and a final crown. Now, in this situation, if you just go put your impression coping, use your PVS material, there is no way your PVS material is going to capture all this soft tissue. Many times when we do our crown prep, we use the PVS impression, but we are not able to capture all the detail because of the void. Do you really think this much of big defect, the PVS material is going to capture everything? No. If you really want to just give impression and do your lab to do any magic work, you can give it. But I usually like to give, I want to capture exactly what I've spent enough time for 6 months to develop it. I need to give them exactly same model so they can know what to create it, what I want it. And how you're going to do it, it's very easy way. Take your crown out, put the implant analog, take any PVS or putty material, put it around there nicely, pack it, make sure there is no void it. Take it out, take any 15 blade, 12 blade, or any lab blade, go through Mesiodista. Now this is exactly the replica what you have it on your gum area. Now use this model. You can send this model to the lab, but you can still use on the chair side to create your custom impression coping. You already have a custom abutment, now custom crown, and now you need to create your custom impression coping. Traditionally, you have you have usually called, like we call it impression coping. You placed it in that model. The void which you have it, take the flowable composite, fill it in there, and cure it. What you're going to end up with is something like this. Now this is, I call like a custom impression coping. I try to place a little bit flowable material around here also. So when you put your previous material, you have more stability or more lock. Try to be very careful when you're trying to take out this excess material. I usually use the hand and flick off any sharp material because sometimes all those sharp margins are very critical. You don't want to end up taking out. When you do a rough cleanup, put back again. Either you can mark with a pencil or use your slow speed handpiece and make sure you contour that properly. Now, this is the exactly final custom impression coping you're gonna end up with it. Go back to the patient, place it in the healed socket. Now, once you place it, you wanna critically evaluate once you place it. You notice here, when I placed it, there is a 1 to 2 millimeter of blanching of the tissue. You wanna make sure your custom coping is sitting as much as passive as possible. I do not want to create the pressure because I told you, you want to end up with the less and give the lab a room to work around their magic. So you take it out, trim it a little bit, and put it back again when there is no blanching. It should be very passive, fitting, and just like a nice snug there. The way I told you, this part, putting a flowable is not necessary, but I usually like to keep it so that I can have a proper lock and there is no shrinkage. Take your plastic impression tray, make sure you mark it and cut the window around it, and take your traditional impression. Now, if you really look at and appreciate this one, is there is no way any light body or heavy body or medium body material is going to go and capture this much of deep if you have created. Also, if you look at this impression, you can see the crown which you have created is narrow. Look at the tissue and the crown they have. As I told you, always, now I have a more tissue to work with it. So always I try to be under contour. I rather end up with a more tissue so the lab can give me exactly the way I want it. Look at the platform from the implant to the free gingival margin. You're going to have a very much of at least 4 to 5 millimeter zone. This is a custom abutment we were able to create it. Remember, I told you I was not worried about the having a facial access hole because I knew exactly I can change through the custom healing abutment and change it to the palatal aspect. I choose the gold abutment at the time because of the aesthetic reason. Once you get it from the lab, make sure you try it on your soft tissue model. You see that it's still coming out of the facially, but there is no problem because it's going to be cement-treated crown. You take this, place it in that socket area. Make sure you check it, everything. There is no kind of passive. There should not be any kind of pressure. If it's a pressure, make sure you trim it, polish it. This is the day of delivery. There is no facial access hole is visible. If you look at the buccal profile, no blanching on the tissue, stapling of the gingiva, and very nice interproximal papilla you were able to create it. Shade of reflection zone. You use the camera to give as much as I use my camera so much in any time when I use it for shade selection or the same, or any kind of crown work or any aesthetic crown. This is the side tissue profile if you look at it. This is the lateral tooth. If you remember, patient actually came with the defect on the buccal side. We did not raise the flap. We haven't done any kind of bone grafting material. Just with this playing with the soft tissue, we were able to create this profile. It is exactly matching to the contralateral teeth and without any recession. Without any kind of provisionalization technique, you will not able to get this papilla formation. So basically what you wanted, once you create that soft tissue on the patient mount, you need to replicate chair side so that you can provide the lab enough information for them to create the soft tissue model to work in the lab. If you give them proper information, they will be able to give you from your that's temporary crown to the model, soft tissue model, exactly the final result. Now, this is the part when you get your lab work back, make sure you try your temporary crown, and it has to be exactly the same way you want it. If it's not fitting well, if there is a short, if it's longer, if it's creating pressure, send it back. Ask them to correct it. You do not want to bring the patient back, cement it, and making patient upset. So this is a very critical. If you follow all the steps I told you, your lab have enough information to work around it. Your lab technician will appreciate your effort much better because you are giving them more information than anybody who's giving them. I want to thank you, Dr. Chaudhary. This is the time I met him on the 2019 in ICOI, where he was giving on the podium about his simplified approach. It was an honor to listen to him on that one because having anybody as a fellow Indian on that podium, ICOI is a very big podium. Listening him, providing his simplified approach was like a commanding. So I really want to thank you, Dr. Chaudhary, for giving me an opportunity to and share my techniques of provisionalization and the custom healing department with all of you. If you have any question or anything, or if you have any question regarding the technique, how to take the impression or any technique with the photography, I love photography. If anybody wants to know what camera and everything, you can email me. You can contact me. That's my phone number. Most of you are from India. You can contact me through the WhatsApp. I use the WhatsApp a lot, and any email. Any question or anything, Doctor?
Thank you, Dr. Vikas. Thank you so much for your input. I was really impressed with the technique. Actually, it's quite a simple one and can be easily done by our people. Like otherwise, usually digital we cannot. Most of the, as we discussed earlier, most of the clinics in India don't have. But what you showed is simple. Without a digital, also can be done. And it is, I think, was informative to all the participants here. Anybody has a question to ask to Dr. Vikas? Can you, okay, I think, yeah.
Yeah, I'm going to stop sharing it. So you can.
Any questions? You can unmute yourself and ask a question, please.
Hello.
Yes, Manish.
Yes.
Go ahead.
Yes, sir.
Hi,
My
Manish.
question, my question to Vikas sir is, when you are doing a flapless tooth extraction and putting the implant, many a times what we have seen is the buccal bone is quite thin and very deficient. So how do you exactly anticipate how much of the buccal bone will be? Because majority of the time, when there is a trauma, when the patient has broken the anterior tooth or it has come off, most of the time, whenever we raise the flap and see the buccal bone, there'll be even sometimes there'll be a dehiscence or some opening, which invariably requires some amount of bone graft, definitely. So in most of your presentations, you have done without raising even a single flap, except the one which was already extracted long time back. And it was mostly a soft tissue maneuver what you had done, very minimal of the bone grafting. So how do you anticipate where the bone graft will be required, or whether the dehiscence will be there or not, or how much of the buccal bone thickness is ideal for me to, without raising a flap, to put the implant back there?
Okay, it's a very interesting question, Manish, and thank you for asking that, because the idea for presentation was very minimum for soft tissue. Of course, there are situations where I've ended up with this, and the way you say it's a dehiscence. If you notice there's any dehiscence at the time, that would be a time to carefully select the implant in the immediate area, because if there is a dehiscence, it's going to be very, very hard to create that bone graft. Now, it depends on the dehiscence. If your dehiscence and if you have like a mesial and distal area, if you run the imaginary line, and if they are going in the front of the implant, you can still bone graft it. But if your implant is coming in the way, there is no way. If you place the immediate implant, you're going to have an ideal approach. Now, if you have a thin bone, that's the time I would even want you to consider immediate implant and go for the immediate implant, because when you have a thin bone, you do not want to raise the flap, because there is a theory where you raise the flap, you disturb that blood supply to them, and you will end up with even more resorption. So at the time, you want to do it as much as flap as possible. What you can do it, if you have enough bone available on the palatal aspect, try to make your osteotomy more palatally. And any jump gap, you can start placing the bone graft material in that one, so that you can give enough stability to your thin bone. Once you become a very skillful, you can even try the partial extraction therapy. But as I told you, I would not advise you to begin with. It's because it's a very challenging technique. But if you even don't do a PET technique, and if it's a very thin bone, carefully once you take out the tooth, take your probe or the spoon excavator and see if you have a bone. Even if it's a thin, you can still place the implant, place the bone graft material. Now, what you can do with this is, if you are careful enough and you have a soft tissue, if you know how to use the soft tissue from either palate or from retromolar area, take out the subepithelial tissue and place it in the gap, and you will be very much easily get away without having to worry about the resorption.
Okay, thank you so much, sir.
Did I answer the question, or do you still have it?
Yes, sir. Yes, sir. Correct. Yes, sir.
I understand it's a very thin bone, but that's the time usually you want to avoid. I would say instead of taking the flap to begin with it, this is how usually I do it from my techniques.
Okay.
I try to go with the mind that, okay, I'm going to place the immediate implant. I take the tooth out, and I do not pick the flap until in extraction socket. If I see I have break the buccal bone, I take the flap only if the buccal bone I broke it. That's the only time I take it out, because I do not want to disturb that blood supply.
Okay. Thank you, sir. Thank you so much.
Yeah, I think it's midnight for Vikas. So I really appreciate you staying awake for. I think it's more than 12 noon now with Dr. Vikas there.
It's 1:45.
Oh my God. that will not hold you. I
don't mind if anybody has any question or anything.
Yeah. So anybody has a question, or we will close the session? I think we thank you, Vikas, for giving a wonderful presentation. And from the host disabled transfer. Okay, so can you just stop sharing? I think I'm not able. Can you make me the host, please?
I'm going to make you
Yeah.
Yes, I'm going to make you the host. Right?
Thank you. Thank you. Thank you so much. Yeah. So from the Brunimark Center, we would like to appreciate, and this is a token of appreciation, Dr. Vikas. Please accept the certificate of appreciation, which will be posted to you and sent online also.
Thank you. Really, really
Thank you so
appreciate that.
Thank you so much. Thank you so much. And I'll catch you later again. And thank you so much for being our guest today. Thank you.
Thank you.
Thank you all participants for attending the webinar. Thank you so much. Stop it here. Okay, and here.